We're going to talk about the metastatic non-small cell trials that were presented. Specifically, when jump to some post-hoc analysis of the brain treatments from the 9LA and the TASO brain trial. So, Andy, go on. So the question is, does immunotherapy in combination with chemotherapy benefit patients that have metastatic non-small cell lung cancer that have brain metastasis? So the first two trials are just post-hoc analysis of the 9LA, and the second one is a TASO brain trial, a phase 2 study. Go on. So this is just a real quick summary of it. I know most of us are very familiar with the 9LA study, which takes nivo, ipi, and chemo compared to chemo alone. But the TASO brain did something similar to chemo and TASO, but it was only a non-squam arm. So it just used the platinum doublet, carbo, and PEM. Whereas, as we know, the 9LA could be both squam and non-squam. And I thought this was very interesting. What it clearly showed is a significant improvement in overall survival in patients that had brain mets. There was a significant improvement in 2-year survival, significant improvement in progression-free survival, and a lot of the benefit was actually intracranial progression-free survival. So I've heard some oncologists talk about, well, are immunotherapies beneficial in patients that have brain mets? And these two trials, even though one's a phase 2 and one's post-hoc analysis, in my opinion, clearly demonstrate that big, significant PFS and OS advantage in patients that have brain metastasis. Now, in the TASO brain trial, it was a phase 2 trial, so there was no comparative arm. But if you look at the PFS, it's very similar to what I think the PFS in the 9LA arm is. What was not as similar was the OS advantage, and that's because in the 9LA arm, the patients could be treated and were treated in order to get on the trial, versus the TASO brain, they were untreated asymptomatic patients. So again, I think this does answer the question, is there benefit in patients that have brain mets? So I've always talked to my partners about using chemoimmunotherapy in people that have brain mets. Some of them say, hey, listen, is it really worth it? Is it going to cross the blood-brain barrier? And I think the answer is a definitive yes. Go on. So again, just the impact slide, immunotherapy plus chemotherapy in the first line setting provides benefit regardless if they have brain mets or not, but I would argue that it significantly provides benefit in people that have brain mets. Next slide. So now we're going to talk about a little more actually treatment slides. The first one is Destiny Lung 01. Go ahead. And it answers the question, does trastuzumab deruxtecan, T-DXd, provide benefit in patients that have HER2 mutated metastatic non-small cell lung cancer? Next slide. So this was a multi-center international double cohort phase 2 trial. I thought this was an interesting trial design. What it did is it took unresectable, metastatic non-small cell lung cancer patients that were refractory to standard treatments. They could have metastasis in the brain, but they had to be asymptomatic. And you could either be HER2 mutated or HER2 overexpressing, as defined by being either IHC 2+ or IHC 3+. In the cohort 2, they used a set dose of 6.5 milligrams per kilogram, but in cohort 1 and 1A, they used different doses of TDXD, with the primary endpoint being overall response rate. But more importantly, they looked at the secondary endpoints of PFS, OS, disease control rate, and also they need to look at safety. So the data cutoff for this trial was in May, about a year ago, and we can go on. So the demographics for this group of patients is kind of what we would expect. Slightly more female predominance, a little bit younger than the typical lung cancer patient. Race was, I'd say, predominantly Asian and white, about 88%. This was an international trial, so a quarter of the patients were Asian, about a third were European, and a third were North American. The majority of these mutations were kinase domain mutations. About a third of patients had asymptomatic brain mets to begin with. And not unexpected, because this is a driver mutation, about 57% of people were never smokers. And 40% were former and limited smoking history. And about a fifth of them ended up having prior lung resection for limited disease. Next slide. Almost everybody did have some prior anti-systemic chemotherapy. Predominantly about 94% had a platinum-based chemotherapy. Some patients had anti-PD-1 as a single agent therapy. Some people had combined platinum plus anti-PD-1 therapy. And interestingly enough, they did allow patients to be treated with a HER2 TKI, either afatinib, pyronetinib, or positinib before, but you could not have received an HER2 antibody, nor could you receive a HER2 ADC. So again, you could have I'd say a weak HER2 TKI, but you cannot have a HER2 antibody. Next slide. So the overall response rates, which I thought was pretty good for second or third line treatments, was about 55%. The majority of these patients either had a PR or stable disease, with a disease control rate of about 84%. There was one CR. The median response was about 9.3 months, and the median follow-up was about 13 months. So again, a slightly higher response rate than is classically felt to be in the second leg and beyond. But I think, again, a lot of this was because these were mutation-driven treatments. Next slide. So this is just a waterfall plot looking at the percentage of tumor giant change from baseline. But the reason I like this slide is it actually defined what patients had the HER2 mutation versus who responded versus who had HER2 protein expression versus who had HER2 gene amplification, and which people had the prior TKIs. And when I kept studying the slide, I was trying to figure out, is there a pattern? Is there a pattern? Is there a pattern? I really couldn't find one. You had both people that had HER2 protein expression that did not get a response. You had people that had no HER2 protein expression get a great response. So I think it's classical being felt that these medicines are better for HER2 mutated patients. But I'm not sure you can quite say that people that don't have protein expression don't get a response based on this waterfall plot. Next slide. So this is a subgroup analysis of the response rates in the treatment arms. The majority of these patients had a HER2 domain, and the kinase domain was the most common mutation, and about 57% of those got a response. People that had prior platinum-based chemotherapy by itself had a response, but interestingly enough, people that had both platinum and PD-1 therapy had about a 65% response rates, meaning people with prior immunotherapy treatment actually responded better than people that had not had any by itself. If you had brain metastasis, the response rates were about the same. So about, again, 50 to 55% had a response. Next slide. So this is a progression-free survival curve. It's again, phase 2 trial. So really the dark blue curve is the treatment, and the two light blue curves are just the confidence intervals on both sides. And overall, there was a median progression-free survival of about 8.2 months. But if you go out further on the slide, at 18 months, still about a third of patients had some progression-free survival. Next slide. And this is the overall survival data. So again, these are patients that had previous treatments, and to get almost 18 months of overall survival, I think is very impactful. Next slide. This is the overall safety data. I know most of us are aware now of the treatment-related AEs and the fears that we have, including interstitial lung disease or pneumonitis. that can occur. What they felt was that treatment-related AEs greater than 3% was a little bit high, 46%, but the serious drug-related were only about 20%. And again, I think this is pretty consistent with what we think when patients or physicians of us use Enhertu for treatment. Very, very similar for breast cancer and gastric cancer. Next slide. So this is a slide just looking at the adjudicated drug-related ILD and pneumonitis, trying to show we're at grade 1, grade 2, grade 3, grade 4, grade 5. Unfortunately, there were 2 grade 5 events, but the majority of these patients were grade 1 and grade 2. I think as a lot of us become more familiar with these medicines and we can recognize early signs of pneumonitis, grade 1 is truly just a definition of radiographic evidence of disease. We are now able to prevent, more serious grade events. But I said there were 2 grade 5 events that did occur. Next slide. So in summary, I do think that T-DXd demonstrated efficacy, pretty much consistent across all subgroups, including those that had CNS metastasis. They did do some exploratory analysis looking at, the different HER2 mutation subtypes, as well as patients with no detectable HER2 protein expression or HER2 gene amplification. Overall, the safety profile was very consistent with what's been reported before. And again, I think as more and more of our colleagues get more and more comfortable and more experienced with these type of medicines, we will be able to recognize pneumonitis earlier and hopefully prevent these higher grade pneumonitis complications. And what they decided is they're going to use the lower dose of 5.4 milligrams per kilogram dose in future studies. Next slide. So as an impact trial, I think trastuzumab deruxtecan clearly provides benefit in the second plus line setting and supports the development of a potential new treatment standard for those patients that are HER2 mutated in the metastatic non-small cell lung cancer. And as of April 19th, just recently, there's acceptance of the supplement for the BLA for Enhertu for the treatment of these adult patients. And they've been received prior systemic therapy, has been granted a priority review. Next slide. So we're going to talk about the Empower Lungo-1 trial. Go ahead, next slide. So on February 22nd of last year, the FDA approved Libtayo for the first line treatment of metastatic patients that have non-small cell lung cancer whose tumors have high PD-1 expression. Next slide. And so what the Empower Lung-1 clinical trial tried to answer the question, does semolipimab provide benefit for patients with locally advanced non-small cell lung cancer who have a high PD-L1 expression? And this was kind of a post hoc subgroup analysis. Next slide. So I think most of us are very familiar with the study's design. It took as a phase 3 trial that took patients that either had stage 3B or stage 3C and ineligible for definitive or concurrent chemoradiation or with recurrence after initial treatment with concurrent chemoradiation. And they divided them into chemotherapy for 4 to 6 cycles or semolipimab for every 3 weeks until progressive disease or up until week 108. Next slide. And of note, I've noted that you could have crossover in this trial. Next slide. So the characteristics were, I think, pretty well balanced. Median age was about 63 years. Slightly male predominance for sure. As we'd expect, a lot of smokers in this trial. Squames or non-squames, I was a little surprised. There are clearly more squames in this trial than non-squames. At the initial stage at screening, it was stage 3B, stage 3. So majority of patients were actually stage 3B. And they looked at PD-1 expression, and they, because this was high PD-1 expression group, they actually subdivided it into those with greater than 90%, those with 60 to 90%, and those between 50 to 60%. Next slide. So this is the median duration of exposure, how long do they get treatment? And so, on this slide, there is about a 31-week for the simolepimab arm versus 17 weeks in the chemotherapy arm. And there were, I'd say majority of these patients were followed up between 12 to 18 months. Next slide. And so this is the efficacy data, including the overall survival data. As expected at 12 months, the overall survival was much improved in the simolepimab arm with a very impressive hazard ratio of 0.48. And if we look in the PFS, the median PFS was, again, at 12 months was 38.5% versus 5.8% in the chemotherapy arm. Overall response rates were better. PRs were certainly better. Stable disease was not quite as good, but I think that's because most of those people got PRs. With the median duration of response was also impressive at 12.5 months compared to 6.2 months, so almost a doubling of duration of response. Next slide. So I think the summary is first-line simolepimab improves progression-free survival with a 51% reduction in risk of progression. There is also improvements in both OS and overall response rates. Next slide. So this is a first-line simolepimab improves outcomes for patients with locally advanced non-small cell lung cancer with a PD-1 greater than 50% that had no known EGFR, ALK, or ROS1 alterations in this subset of patients. So again, people that had stage 3B and stage 3C disease. And for my last trial, we're going to move on. Oh, I'm sorry. This is a quick summary slide. So to me, when we look at all these different first-line trials, Empower 01, the Keynote 042, and Empower 110, which actually got these medicines approved, what I like to do is they're all slightly different trials, but is the benefit there consistently? And if you look at both the Empower and the Keynote studies, the median OS was almost identical in both the treatment arm and the comparator arm. While we don't have that information yet in the Empower arm, I think one thing to note is these patients in the Empower trial had a better comparator arm, meaning the comparator arm was 15.5 months. So we'd expect to see a better median OS. So it's always different doing these cross-trial comparisons. So I like to look at what I call the delta, what's the change compared to the comparator if they have a similar comparator arms. And so the median PFS were roughly about the same. The overall response rates might be slightly higher in Empower arm, but overall no significant difference. The median duration of response I thought was interesting was certainly favoring Keynote, but again, not the same slide, but I'd like to just do a quick overview summary looking at comparator trials like this. Next slide. And the last one is the Poseidon trial. Go on. So the question is, does frontline durvalumab with or without tremelimumab and chemotherapy provide benefit for patients with metastatic non-small cell lung cancer? Go on. So the Poseidon was an open label multi-center randomized phase 3 trial that really looked at 3 arms, looked at durva plus chemotherapy, durva plus trem plus chemotherapy, and chemotherapy alone. Of note in this trial design, in both combination arms, the chemotherapy was only for 4 cycles versus 6 cycles. In the, I guess, comparator arm, which is the chemotherapy alone, but you could get maintenance pemetrexed in this subgroup if you were a non-squam histology. So the primary endpoints for this trial were both progression-free survival, overall survival. Go on. So the median age for this patient range was very comparable across the arms, about 64 years old. Again, predominantly male. They were also predominantly white, with a lot of patients coming from both North America, Western and Eastern Europe. Former versus never smokers. Never smokers were somewhere between 25% to 17%. A lot of patients, only about 10 to 13% of patients had CNS metastasis, and about 20% of patients had liver metastasis. Next slide. So this is the efficacy slide, really looking at the two treatment or new arms. One is the Durva plus chemotherapy. The other was Durva plus Trem plus chemotherapy. Looking at the PFS arm, you had 6.2 versus 4.8 and 5.5 versus 4.8 with somewhat significant HR values. The 1-year PFS was superior in both arms, 24.4% compared to 13%, and 26.6% compared to 13.1%. The median overall survival was a little less than 2 months in the Durva arm, and about 2.5 months in the Durva plus Trem arm, with 2-year overall survival rates being about 30% and 33% respectively. Next slide. Here's a forest plot looking at what subgroups really had benefit. And overall, the one subgroup that might not have benefit was mainly in the Durva plus Trem arm, was the never smokers. And probably the thought process is they had some unknown or undetected driver gene mutation that was just not effective to be treated with chemoimmunotherapy. Next slide. So these are overall response rates. Certainly, the more drug you add, the higher the response rates. Although I was a little surprised that Durva plus Trem plus chemotherapy was slightly less than Durva alone. Although the duration of response clearly favored that combination, Durva plus Trem plus chemotherapy. Next slide. This is the efficacy in the non-squam histologies. Again, looking at both PFS and OS, both were clearly superior compared to standard chemotherapy, with the OS being about 17 months for the Durva plus Trem versus chemotherapy versus 15 months for the Durva plus chemotherapy. Next slide. This is the squam histology arm. Again, this was a little more surprising to me. It did not seem like there was truly any significant benefit for this squam histology. So it looks like predominant benefit was in the non-squam histology. Next slide. And this just goes what we had just talked about, response rates being non-squam superior, not much benefit for the Durva plus Trem versus chemotherapy. Next slide. These are the safety events. Again, really what we would consider when we use this combination between IO and CTLA-4 and checkpoint inhibitors. There are certainly more and known grade 3, grade 4 events, but nothing unexpected based on the class of medications we're using. Next slide. Again, what sort of immune events were there? Again, all of these things I think what practitioners now expect to see, pneumonitis, rash, hepatitis, dermatitis, colitis, all the normal itises that we see. And of course, they were higher in the immunotherapy arms. Last slide. So this is a summary slide. Durva plus chemotherapy did prolong PFS versus chemotherapy alone. There was a trend towards OS, but did not reach statistical significance. And there was certainly more survival benefit in those with non-squam histology. And in the Durva plus Trem and chemotherapy arm, there were both PFS and OS versus chemotherapy. But again, survival benefits were more prominent in the non-squam histology. So this is one of the first times I remember seeing a huge difference between squams and non-squams with these immunotherapies. Impact slide. So I think Durva plus Trem plus chemo can be used as a potential treatment option for metastatic non-small cell lung cancer patients, but I would have a caveat that I would significantly recommended only in the non-squamous histology group.